Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. Welcome to another edition of It's in Our Blood, and this time we're talking about another women's health topic, or probably more so a family health topic. So today we're talking about prenatal testing, and we're talking about a couple of things. First trimester screening for chromosomal abnormalities, and also for a pretty nasty disorder called preeclampsia, which has quite a high incidence and can be very deadly for bub and for mum. So today, to help us out, we have Tom Berkovits, Director Market Development Asia Pacific for Illumina. So welcome, Tom, to this podcast.
Thanks, Dean. Thanks very much for having me.
So I guess the first question is we want to talk a little bit about what is this testing that can be done now. I know it's referred to as non-invasive prenatal testing, and it's done using technology that uses or incorporates cell-free DNA testing. So tell us a little bit about that. What is the non-invasive prenatal screening or testing, and what is this cell-free DNA testing all about?
Yeah, so NIPT or cell-free DNA testing came about relatively recently. The discovery of cell-free DNA was identified by Dennis Low and colleagues at the Chinese University of Hong Kong in 1997. And probably in the early 2010s, it was determined that you could actually use this technology in the healthcare or in the pregnancy and prenatal setting. And what they discovered was that during pregnancy, DNA fragments are released from the placenta into the maternal circulation as cells apoptose, as they die. And it's now possible with next generation sequencing technology to analyze that circulating DNA fragment using a plasma sample. And in that, you'll see both the DNA that's maternal in origin and placental cell-free DNA. And you can then sequence that cell-free DNA and map it back to its origin, and then count the DNA fragments and screen for chromosomal conditions. And what we're really looking for in this is the ratio of placental to total DNA, and that total DNA consists of both maternal and placental cell-free DNA, and that gives you what's called a fetal fraction, which increases as pregnancy advances. And because the size of the two DNA fragments, the placental versus the maternal, is slightly different, that sizing helps to determine the origin of whether it's placental or maternal.
Wow. I mean, when I was in labs years ago, to determine any of the DNA of bub, you had to take an amniotic solution, amniotic fluid, or even sample a little bit of the chorionic villus, the tissue that makes up the placenta. So is that, and that was pretty hazardous, if I recall correctly. There was a reasonably high complication rate associated with that. So is that done any longer, or this overcomes the need for that, right?
No. So it's still very much done. So I think it's really important to emphasize that NIPT or cell-free DNA testing is a screening test. And so it's not a diagnostic. And so you use this test or this technology either in place of or in conjunction with the standard first trimester screening tests that are available. And if you find that you are at an increased risk or you are positive for one of the chromosomal conditions that we look for, then you still need to go ahead and have either a CVS or an amniocentesis to get a definitive diagnosis. And the amnio or the CVS is done depending on when that diagnosis is made. CVS is generally done in the first trimester. Amniocentesis is largely done in the second trimester.
Okay. So why are people opting for an NIPT type test in the first trimester?
So there are several reasons for this. I think what patients ultimately would like to do is to have as much knowledge about their pregnancy as they possibly can. This particular test has much higher positive predictive value, much lower false negative rates than what the traditional serum screening options provided. And so in the current state of testing that gets done, if you do any one of these tests on their own, which tend to be in the first trimester a nuchal translucency ultrasound, and likely that in combination with first trimester blood screening, you're looking at detection rates of somewhere between 80 and 90%. And then as you move into the second trimester, you add another serum marker and you do a quadruple screen. And again, if you combine that with nuchal translucency ultrasound, you're up at around 94, 95% detection rate, but that still leaves you with a false positive rate. NIPT has a much lower false positive rate, and so it's much more specific. It can be done a little bit earlier in the pregnancy as well. And non-invasive is, I guess, to some degree a misnomer. It's a blood draw, but it doesn't require the invasive procedures that you mentioned before, either CVS or amnio.
Got it. Okay. There is still a role for the biomarkers, though, the blood biomarkers, isn't there?
Yeah, there is. And biomarkers give you information just like what the NIPT test can give you as well. And I think, it's really important that we emphasize that the basic principle of screening is to offer safe, and accessible testing to all pregnant women. And ultimately, we're trying to identify those women who have an increased likelihood of having a baby with a chromosomal or genetic condition. But now as well, we're seeing that some of these conditions enable us to manage pregnancies better. So if people have one of the non-traditional trisomies, maybe a trisomy 9 or a 16, that might be indicative of some complications in a pregnancy that may not affect the fetus, but might make the pregnancy a little more challenging. And so doctors can then, depending on the mother, manage that pregnancy a little more effectively as well. So the role of the serum screening is still there.
Yes.
And the ability to do prenatal genetic screening as well enables us to give women more information and heighten their understanding of the risk of carrying a fetus with one or more fetal aneuploids. And it's really important that we understand that there are two basic types of aneuploidy. There's trisomy, where you end up with 3 copies of a specific chromosome, and then there's monosomy, where you end up with 1 copy of a specific chromosome. And depending on the chromosome and depending on the pregnancy, these can be quite significant in their effect on the fetus, or sometimes less so.
This podcast is brought to you by Pathology Technology Australia, the peak body representing the companies who invent, manufacture, supply and support the vital technology needed for testing those precious patient samples. Did you know that pathology tests provide vital information for about 70% of medical diagnosis and 100% of cancer diagnosis? Pathology Technology Australia, representing the companies who provide the innovative technology so critical to a high quality, affordable and accessible healthcare system. I can see then there must be a role for both here, the blood biomarkers and the non-invasive prenatal testing. And I know I mentioned at the beginning preeclampsia. preeclampsia actually has a higher incidence than the aneuploidies or the chromosomal disorders in incidence in babies. And so, in a sense, that's possibly even a more concerning healthcare condition in pregnancy. I think around between 5, 6 or 7% of pregnancies are affected by preeclampsia, and this results in the pregnant lady encountering some very high blood pressure, and it can lead to other organ failure if it's not kept in check. I'm aware there's a blood biomarker that can also be tested here. So I guess what I'm saying is that the combination of blood biomarkers and the chromosomal testing with the cell-free DNA gives you probably the best of all worlds here. Yeah, it focuses you in on the likely issues associated with the baby, and it focuses you in on the potential for mum to encounter, say, preeclampsia. And the good news about capturing these things up front, as you mentioned, is that you can then make some treatment decisions, you can then make some management decisions. And I know with preeclampsia, if it is detected early in the pregnancy, it's a relatively simple and relatively safe treatment, which is a low-dose aspirin. And it's not suitable for absolutely everybody, but for most pregnant ladies, aspirin will actually reduce the chances of preeclampsia developing into quite a nasty outcome. So tell me about, Tom, how much NIPT testing is done in Australia at the moment? Is there a lot done?
There's quite a bit done, and I would say that the amount of NIPT testing that's being done is increasing significantly every year. So the first NIPT tests were offered in Australia in 2014, 2015. And since then, I think there are now 5, if not 6 different centres, maybe even more now, that offer NIPT. Our estimates are that probably 1 in 3 pregnant women opt to take NIPT testing at the moment. Oh. Unfortunately, it's not reimbursed by the government at this point in time, and that limits to some degree the uptake. But we see steady numbers of probably there or thereabouts 100,000 tests per year being done.
And I guess if more was done, the complications of pregnancy would be even more reduced, right? That's the aim of this here, isn't it? To use the technology to get better outcomes?
Absolutely. I mean, our goal would be to have NIPT reimbursed, and we see that is happening globally, and to some degree Australia is behind a lot of its counterparts, particularly in Europe, where it is being reimbursed now in countries like France. It's being reimbursed in the Netherlands, in Belgium, in Switzerland, in parts of Italy. And then there are various models that are being used, and contingent screening is being reimbursed in the UK starting from later on this year, and the Germans have just announced that they're going to fund NIPT testing as well for people starting next year. So we have had discussions with the government about reimbursement, and we continue to have those discussions in the hope that they will at some point come to the conclusion that it makes sense and it's what's best for all Australian women.
Yeah, I agree. I mean, and that contingent model is I think, the best of all worlds, where you use a clever combination of the blood biomarkers and the cell-free DNA to get the absolute most you can out of this, including preeclampsia. So I think that's a model that would lead to the absolute best outcomes for mum and bub, without doubt. Where can people go to learn more about this, Tom?
There are a number of different resources that are out there. A couple of the big American colleges, so the American College of Obstetrics and Gynecology has quite a bit of stuff, as does the American College of Medical Geneticists. There is some information on the RANSCOG website as well. Mm-hmm. Companies like ours at Illumina have developed specific content for patients and for healthcare professionals, both of which are unbranded. So they have a lot of background just on genomics and genetic technologies, on the variety of syndromes that are detectable by NIPT, and then there are other companies that do similar sort of things. So there's quite a bit of information on the website or on the web, and then there are resources that are available as well. And if people are interested, we do have both patient guides and counselling guides for healthcare professionals that are accessible if people would be interested.
No, that's great. So this is being gene-based testing, DNA-based testing. This is pretty much in its infancy still. Where else do you see this going?
I think there are a number of places that the technology can take us. Clearly, one area that we are looking at is non-invasive prenatal diagnosis. So doing a much deeper level of sequencing to be able to get down below what a current carrier type would provide, taking away the need for an invasive test. That's one area where I think we can go. You mentioned preeclampsia. There's a lot of work being done at the moment on RNA signatures around preeclampsia as well, and ultimately being able to combine the technology whereby you could get an NIPT test and also see whether the markers that would be indicative of preeclampsia in a single test might be something else that would be an area to discover or to explore further. We're also looking at other methodologies or other tests that link in with pregnancy. So Rh status is another one. We're looking at a specific signature around early pregnancy loss for people who have unfortunately had miscarriages, and trying to determine the genetic cause of those as well. So I think there's a number of different places that the technology can take us. As with everything, it's sometimes that the technology moves ahead of both where society and where the ethics around this want to go.
And also our ability to, I guess, show the clinical utility and the value as well. And that's a topic that maybe I'll discuss in a later podcast. Look, I think it's clear here that the technology offers us some extremely important insights into the health of mum and the unborn bub, and where and how better to manage a pregnancy. And I think this is an incredibly important area. And I wanted to thank you, Tom, for helping illuminate a lot of this, and really appreciate your time. So that's the end of this podcast, and please look out for more podcasts around women's health. Clearly, we'll also have some men's health topics coming up as well. So that's all for this edition of It's in Our Blood. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series, or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.